Good afternoon, everyone, and welcome to breakout session 4, which is social prescribing, the Trojan horse in the ICS. So I would like to introduce myself. I'm Sian Brand. I'm co-chair today with Craig Lister, who'll be introducing himself in a moment. I am a steering group network core group member of the National Steering Group with Marie Polly Michael and a number of other colleagues here today. And today's session will be really focusing around system-wide social prescribing. How do we take it from just that link worker model out so that everybody is involved in collaboration? So I'll pass over to Craig to introduce himself before we start the session.
Thanks, Sian, and good afternoon, everyone. My name is Craig Lister. I know quite a few of you. Previously, I was Managing Director of Green Gym, and funded by the National Lottery Community Fund, I wrote the Equality Assurance for Social Prescribing document and supported all the colleagues you see here on the wonderful journey of social prescribing. Now I've moved back into the NHS. I moved between the voluntary sector and the NHS. I'm now an Associate Director leading on IMS and VACs across Bedfordshire, Luton and Milton Keynes, which is an area where I see social prescribing can significantly support the inequalities agenda, which Michael so eloquently talked to earlier. So I'll pass back to Sian. Thank you.
Thank you, Craig. So we have two speakers here, well, two sets of speakers here today. We have Herts' model of social prescribing, and we have three wonderful speakers. They're going to be kicking off for us, and then after that we'll be moving on to Dan Hopewell for Bromley by Bow in London. So with no further ado, I'd like to introduce Tim Anfilogoff from the CCG, Marianne Lindsay, and also Kristy Thakur from the council. So Tim, over to you.
Thanks very much, and hello everyone. And it's very exciting. I got one of those reminders you get on Facebook yesterday, I think it was, because it was 6 years since the parliamentary launch of the National Social Prescribing Network, which I think Sian, Craig, Dan, we were all at. And in that 6 years, as you heard today, since then we've got 2,000 extra link workers, and the change is huge. We called this the Trojan horse, or used the imagery of the Trojan horse largely because Michael likes to talk about social prescribing as that, in the sense that it was about trying to socialise medicine, because we kind of assumed that medicine didn't want to be socialised. And I think the talks this morning give us real hope that actually the ICS, and we'll say a bit about that in a minute, is there to help with that process of socialising medicine. And we need to challenge that rhetoric, but I think it's a really promising place to start from. I'm just going to do that thing where I start showing you my emails. But hopefully it will work beautifully. The other thing I wanted to really stress, not to show you my emails, hang on, is that we, as the local authority in the form of Kristy, the voluntary sector in the form of Marianne, and the NHS in the form of me, hence I'm wearing my lanyard. And this time I'm going to try and connect to the right document. And off we go. Can everyone see them?
Not yet, Tim. There we go. And just put it into slide presenter, you'll be fine.
I've got a blank screen. Oh no, there. Okay, can everyone see that?
Yes. Yes.
So we're very much looking at how social prescribing gets inside the system and makes it work better. And those are our titles and names. I won't bore you with that. And I think this has come up several times this morning, really, that too much of the biomedical model is not focused on the lives that people are actually living. And I don't think we need to spend long on that slide. And similarly, Michael made all these points incredibly powerfully. we know that deprivation has huge impact on people's health and well-being. I could say a bit about our integrated care system. It was great hearing from Darren about Devon, and in some ways quite jealous because it's a much simpler structure than we have in Hertfordshire and West Essex, because Essex is actually split into 3 different ICSs, and West Essex is part of our one with Hertfordshire. But we've got a population of 1.5 million, budget of about 3.2 billion, and we've probably got about 100 link workers in total across the footprint, both in the primary care networks and in the community. And you can see we're right next to London, which also creates all sorts of problems, but it does make it very easy to go to Bromley by Bow and learn from people like Dan, so that's very helpful. And the professed intention of integrated care systems is to bring together the local authorities, the NHS and other partners to focus on that population health management agenda that you've heard so much about this morning and improve those outcomes, tackle inequalities. The other 2 bullets are also very important, but we're not going to focus on them so much. But actually, we think the Hertfordshire voluntary sector in total is worth about £1 billion. So even though not all of it has anything directly to do with health and well-being, it's still a significant economic player. I'm going to hand over to Kristy now to say a bit about what the voluntary sector has been doing during COVID.
Hello everyone, my name is Kristy Thakur. I am the Head of Community Wellbeing, which is part of Hertfordshire County Council. It sits within our Adult Care Services Department. My team commissioned the voluntary and community sector to provide preventative services. And an example of those preventative services are what you can see on your screen now. So I have a budget of around 12 to 14 million. It's not the same each year, and it's definitely, we have received increases in funding due to COVID and subsequent COVID recovery, hence why it's the last year it's probably been closer to 14, 15 million. Some of the provision that we commission, dementia support, carer support, we have large organisations in Hertfordshire, large community voluntary sector organisation called Carers in Herts. We've got Age UK that support Herts-wise dementia contract, crisis intervention service, which is for people with financial. Tim, I've lost the slide. Lovely, thank you. That are in financial crisis. We provide befriending, we provide food support, Meals on Wheels, information, advice and advocacy, and support for those people that are affected by long-term conditions. And just a few of the stats there for you, just to show what happened during the COVID pandemic. The voluntary community sector within Hertfordshire were absolutely outstanding, and they were able to provide a really responsive, flexible provision, and they literally stood up overnight when the pandemic hit. So we had over 11,000 volunteers that wanted to support, especially during the pandemic. Calls to Herts Help. So Herts Help's our independent advice and information and advice line, and the calls literally trebled overnight. So we were going from 35,000 calls per year to 140,000 calls. So you can see that massive increase. I think that's an increase by 300% nearly. We had 35,000 residents supported by our Citizens Advice Bureau, so they with complex debt and financial support. We had 12,000 referrals to our community navigation service, of which Marianne is the manager of. And we had 600,000, I can't see the number there, sorry, 600,000 heated meals delivered by Hills, Hertfordshire Independent Living Service, our Meals on Wheels provider. Can you go on to the next slide, please, Tim? Some more, so some of the other work that we've done, again, because of the pandemic, we wanted to work with our real grassroots community and voluntary sector organisations and faith organisations to support vaccine take-up. And we had some money from public health, our public health department, to help target some of those communities that were not taking up the vaccine. From the statistics in Hertfordshire, we were seeing that communities such as Black African Caribbean communities and Egyptian traveller communities were. Tim, are you able? Sorry, I'm just pausing for the moment. Tim, are you able to put it onto slideshow? Because I think people are having difficulties seeing the slide.
Sorry, I don't know why it came off. From current slide. Yeah.
That should do it. Well, once Tim does that, I'll keep talking. So some of those pictures are showing how we use that funding. So we had a lot of kind of family events. So there's pictures of the Polish Saturday School, a community event targeting Bangladeshi communities, Gypsy and traveller communities, and we've got an Islamic centre. So being able to work with the communities and the faith organisations to increase vaccine take-up. So we're really pleased with the success of that. Do you want to go on to the next slide, please, Tim?
I'm trying. Yeah.
Lovely. Okay. So in my previous slide, I talked about Herts Help. So Herts Help is our independent information and advice, and it's our single point of access to community support. So what we always say to everyone, so be that professionals or the public or residents of Hertfordshire, anybody, if you don't know where to go for information or advice, ring Herts Help. So Herts Help operates 7 days a week, and you can also contact them by email, and it has a website as well. And like I said, it's during the pandemic, it really became that first port of call, especially for those people that were shielding. So they were clinically extremely vulnerable or just chose to shield. Herts Help became that first port of call. It was originally commissioned in 2011 and has now really kind of ramped up to deal with issues coming out of the pandemic. It's also our way to access community navigation service or our link workers, so our social prescribers, so that people that do require that face-to-face support can access it. That's a lovely little bus shelter poster as well. No, that's fine. That's our nice little poster that we had these posters during the pandemic, especially supporting people that were financially needed that support. I think I'm handing over to Mary-Ann now to talk.
No, it's me.
Sorry, Tim.
But I think it's worth saying about Herts Help that it's a really non-stigmatizing way of reaching out to people and saying you can ring about all these different things. And although that particular poster is about paying the bills, obviously there's all sorts of other issues that people might need to ring about. And back in 2014, when I moved from the county council, doing a very similar job to Kristy's, to the CCG, we had GPs saying, we've got all these people coming to see us and we don't know what to do with them. And actually the CAB survey at the time that ComRes did showed that about 20% of face-to-face time of GPs was spent on stuff that wasn't about medicine primarily. At the same time, Herts Help was saying to us, we're getting calls from people who need a lot more support than we can actually give over the phone. They're getting confused, they don't understand, and it'd be really good to help work with them more directly. And that's why the Community Navigator Service was set up. It was very much something that GPs wanted, but also working with the council and the voluntary sector itself, we worked out a way of doing that, which was to set up a system with 5 community navigators back in 2014. And the important thing about it, there were 5 in a team working together. Although they were covering a ridiculously big population of 600,000 in theory, we knew we wanted them to work in an integrated system, not least because we thought they'd probably tell us things about the services that were missing that we needed to hear as commissioners. And if we'd had everything done separately, the way the PCN link workers had been commissioned, we wouldn't have got that. And as at 2022, it's now a partnership of 9 voluntary organisations with about 75 staff, and Mary-Ann will tell you more about that in a bit. But hat tip to Dan and his colleagues. I mean, obviously, we were making this up as we went along, and I think actually, although everybody's heard of Bromley by Bow, not everyone had heard about social prescribing, and I think that language was quite new to a lot of us. So we'd worked with the voluntary sector in lots of different ways, and a lot of this stuff was fairly sort of being done in different ways, but not in the kind of integrated way which we're now talking about. But I think it's important to stress that we never had an eligibility criterion other than the GP didn't know what to do with you, and that hasn't changed. And the great thing about Herts Help is that if you don't need a link worker, that's great. We don't say you've come through to the wrong person. We'll put you in touch with other people who can help you directly. But we always wanted to do the learning from that systemic approach, thinking about the population health management stuff, the gaps and strengths in the commissioning, learning more about accessibility, because so much of the casework was actually people who just lost their way, and the health per se wasn't the biggest part of their problem, it was their lives. And it's taken a while to get the data into the shape that we wanted, but we've now, within the Hospital Community Navigator Service in Hertfordshire, we've got 20,000 referrals a year that we're getting data on. And the other thing, and it very much links to the Herts Help approach, is that we've not traditionally as a public sector made it easy for people to get help. I mean, obviously the NHS is there and people turn up at A&E or they go to their GP service because they don't know where else to go. But we haven't made it easy to find wellbeing services, ways of not being lonely. That's all quite new, really, in the way that social prescribing is developing that. And you don't really need to be a Nobel laureate to think it would probably be helpful to make these things easier. And just to give you one example, this is not his real name, David, but our link workers visit people at home, and clearly you find out all sorts of stuff by doing so. This was a guy who was hoarding, his property was unsafe, he was stockpiling food which was rotting, his bedroom and bathroom were unusable, he had no heating, lots of debt. Very interesting talk this morning about that and how so many of those people are just sitting on that without any help. He was lonely, he couldn't use his garden, which he used to really value because it was overgrown and cluttered. And actually he was waiting to have a heart operation. So understandably, the referral was made to try and help with all of that. And as we go through the talk, it's worth just thinking, what would have happened if he hadn't had access to a link worker? Because that's an awful lot of stuff to sort out. And the other thing to say in all this and why link workers are so important, is that the system kind of assumes that you'll just approach when you have a problem, but that's not what happens. People aren't like that. They're scared of opening the can of worms. But it's not just the client who's scared about opening the can of worms. It's often also the professional. And when we're thinking about how people make contact with services, it's worth thinking about these three columns, really, because obviously if the professional knows all about social prescribing in the voluntary sector and has time, and if the person themselves is quite happy to have that conversation, doesn't mind telling people about their debt, great, it's all going to get sorted quite straightforwardly. But in the middle, you've got the column where the person doesn't want to have that conversation. And there you've got a chance, if the professional knows about the service, has time and skill to unpick with that person. But a lot of professionals don't have that time. And then, of course, you've got the situation where neither professional nor the person wants to have that conversation. And for years now, I've thought there's a kind of mirror image here, because I think for some of those professionals, very busy professionals, they know they've only got a very limited amount of time. They've got people queuing down the waiting room. They can't easily start that conversation. And similarly, whether you're a family carer looking after a dementing mother, or someone with a low-level mental health problem or whatever, you may not find it easy to talk about that. You might find it much easier to talk about your bad knee and never get onto the bit that's actually really affecting your life. So it became clear that we needed to help both sides of that equation to have that conversation. And obviously the community navigator model fits very, very well with that. So as we go forward and trying to make sure that the ICS fully makes use of social prescribing, what we started to look at is a health creation strategy. So it's really good to hear Maren talking about that whole approach earlier, because we've stolen all of that from her. And we're looking at making sure that all the commissioning of the voluntary sector across Hertfordshire always looks at the whole issue of the way in, the no wrong door, making it easy to get in there. And obviously Herts Help is a really big part of that. But so is the sort of stuff that we're talking about this morning around debt and reaching out to people and saying, you've probably never heard about the fact there's a debt service, but we can help you sort some of these problems out. And actually, it's in the interests of the creditors and the social housing people as well that we sort this out. So let's work together. I thought it was a fantastic example this morning. And we know that family unpaid carers have much worse health than their peers. Some of them have not had a break for 2 years now, all sorts of additional problems. We need to be reaching out to them, as well as making sure that all of our commissioning has benefits for them. And likewise, the role of volunteering, which we know is good not just for society, but for the individual themselves. I think it was Merrin again talking about reciprocity and how important it is to be able to contribute, and how we can do that through some of the commissioning we're already doing. Over to you, Kristy.
So I think I may have spoken about this earlier. This is, I've got a bit of an echo. Tim, can you mute?
Can try.
Thank you, lovely. So this is the Household Support Fund that we received. Hertfordshire County Council received 6.1 million of that, so that's DWP funding. And we also, as a council, have a programme called Building Life Chances, which again is around COVID recovery funding. So all of this funding is to really support vulnerable households with those real basic essentials. And I think it's, as you'll see as the slides come by, I think it's going to be really scary, the situation that we find ourselves in, with energy and gas prices going up. So as you can see, in terms of what the funding is being used for at the moment, it's for food support. So it's for basics. It's not for any niceties. It's for basics to support Hertfordshire residents. So food support, in particular food support for children that are receiving free school meals. So for them to receive that during the holidays, school holidays. There's also support for energy and water and other essentials, and other housing costs as well related to that. Next slide, please, Tim. And again, going back to Herts Help, I think this is where Herts Help is absolutely key, because all of these people that are now find themselves in financial hardship because of the pandemic or because of the consequences of the pandemic are able to go through Herts Help, which is a non-judgmental way. And like we said earlier, if you don't know where to go for support, go to Herts Help. That's just what we say to, same thing that we say to professionals, as we do to the public. And Herts Help call handlers are able to provide a skill triage. So, for example, if somebody is ringing up, where we were talking about David, they're ringing up, they've not just got one issue, there's a multitude of issues, and the Herts Help call handlers are able to really expertly get behind that, and if needed are able to arrange that face-to-face with a link worker. So, you know, nobody's left kind of without any support. You know, they will be either guided, you went through quickly there, Tim. They'll be either guided to the right provision or they'll receive a link worker support. Sorry, I will go on to the next bit now, Tim. So just again, switching back to what I said about the financial crisis situation that will be hitting the residents of Hertfordshire. So as I said before, we have a financial crisis intervention service, and I just really wanted to show this graph to you all, just to show the situation that we will be in. So where we were spending, as you can see, in 2016, 2017, you know, 51,000, 60,000, whatever, to support residents of Hertfordshire financially. That has now gone right up to 394. It was in 2021. The stats at the moment, just for January and February alone, we are at 100. We're spending 185,000 supporting residents, which would mean that we're looking at a predicted spend of around £1 million. Now, I know that is due to the fact that we have this additional government funding, so that does skew it. But I think, again, I just really wanted to reiterate that situation, that financially, a lot of people that didn't need help are now needing help due to that pandemic. I think that's now handing over to Mary Ann, who manages the Hospital and Community Navigation Service in Hertfordshire.
Great, thanks, Kristy. Oh, got enough echo there. Hi, everybody. So I just thought I would, so my name's Marianne. I'm employed by the British Red Cross, and I manage the service, and it's an integrated team of different link workers within the community, within GP practices and within the hospitals, all employed by 9 different voluntary sector organisations. So just looking at the operating model that we have with Herts Help, that's the telephone support, and we are the face-to-face support within the community. So we've just received about just under 15,000 referrals for Q1 to Q3 this year. And 20% of those referrals are for hospital discharge support, and the other 80% of the referrals are for social prescribing, whether that's from the GPs. I think they account for about 26% of our referrals, and the rest are from the community. So it's really important that we're integrated within GP practices, within the hospitals, and within the community to be able to support our clients. So the top client groups that we do support within the service are mainly older people or those that have long-term illnesses or conditions, mental health support, and a lot of carer support we've seen in the last couple of years. That's really gone up. That never used to be on our top 10. So the issues that we're seeing across Hertfordshire, the great thing is we've got this county-wide data. We're able to drill it down into east and west of the county or into localities and further down into districts. So we can actually see which localities have housing issues, which have loneliness, and then we can work with the voluntary sector to support those people. But social isolation is definitely at the top across the county. Mental health, as I mentioned, carer support, debt, finance and benefits, as well as housing, are what we're seeing. So because we're spread across the county and we linked into a lot of community teams, we're able to speak to other organisations to make onward referrals to make sure that those people have support. So we refer on to Age UK, Carers in Hertfordshire, Money Advice Unit, Citizens Advice Bureau for Debt and Finance, Reach Out for Befriending Support. So you can see that the top 5 issues that we support, we make sure we have strong links with those voluntary sector organisations to make sure that that person has support within the community. Next slide, please. So as well as our social prescribing within the community and supporting the GPs, we also support the hospitals, because it's not just practical support needs you have when you leave hospital, there may be social prescribing needs as well. So you have one person to take you through that journey out of hospital with those immediate needs, and then further support through social prescribing. So the hospitals were under a lot of pressure last year, so Hertfordshire County Council found some funding for us to support with an enhanced 2-week wraparound offer, which meant we had 24 to 48 hours to get a bed moved from upstairs to downstairs, to have a deep clean done, to install a key safe so carers could start going in, just so that we could facilitate that hospital discharge and help them to leave hospital in a supported and timely manner. We also started the Pathway Zero a year ago project, which is contacting everybody over 65 who's been discharged on Pathway Zero, so no formal care required, just to see if they need any support. So we contact them on day 1 and offer another call on day 5. What we found is that 9% of those people do require support on day 1 after discharge. 6% is obviously non-statutory support and 3% is statutory support. So they need a district nurse. They don't understand how their dressings work. They don't understand their medication. So we're able to get that support out the day after that they've been discharged. We've also just started last month contacting all those on waiting lists. As we understand, obviously, there is millions of people waiting for operations. There's a backlog. So we're just giving them a call to find out about their mental well-being, to see how they're getting on. And we're actually seeing about 12% now of those that we're contacting do need support with social prescribing, and because they're struggling. A lot of carers struggling because they've been a carer on a waiting list. Their health has deteriorated. The person they're looking after has deteriorated, and they just don't know what support is out there, and we're able to link them into that support. There is some cultural issues that we're coming across on the waiting list, actually, where some people of a different culture feel they don't want to worry their GP, or they don't want to worry their consultant. So we're working with the hospital teams and them to reassure them that the GPs are there to listen, the consultants are there to support you. So that's something good that's come out of these calls as well, that we're seeing to tackle those health inequalities. Next slide, please. So because we're such a large service, 75 staff, 9 different voluntary sector organisations, we can pull in resources to support. So during COVID, we contacted over 6,000 patients on vulnerable lists from the GPs, from housing, just to check in with them and make sure that they were okay. We've also been supporting with the Afghan families and bridging hotels, supporting the Red Cross with that. We've got a veteran project where we're finding ways to find out if people are veterans and how to link them into veteran support, find out the services that are available there and get them linked into the veteran gateway. We're also employing a sensory community link worker. Our data has shown that there has been a real increase in our clients with sensory needs. And so we're specifically recruiting somebody to support with that as well. We were involved in the population health management project, where we contacted BAE males between 40 and 49 who didn't utilise a lot of services and weren't managing their health conditions well. So through social prescribing, we were able to link them into, have that conversation first and link them into the right support that they needed. Next slide, please. Right. So just sort of going back to David's story, he was a hoarder, he wasn't using his bathroom, he had no heating, no hot water, significant debt, lonely, and he was unable to use his garden. So I think the main thing for us is where do you start with this, with somebody who's going through all of these difficulties? And it's really about the non-judgmental support that the link workers are able to provide. And it starts off by building a trusting relationship with that person, because then they would trust that you are there to support them and you're not judging them. So we were able to link him in with advice for benefits, with step change, just so that he doesn't have to worry about that and he could make affordable repayments. Care for Freedom, which is a hoarding service, and they've also got a SMASH group, which is people who have been hoarders themselves, who help others, you know, emotionally and just psychologically to get through that. Herts Healthy Homes, we arranged an emergency heater because obviously we needed to get the heating fixed, which was then done through a community hardship fund, and so he had heating and hot water. He was linked into a Meals at Easter group and also a church coffee group, so he attends that. And Green Aiders cleared his garden. So all of these things improved his living conditions and enhanced his post-operative rehabilitation. And you know, he's doing really well.
Just a couple of more minutes now, please. That would be great.
Yeah, okay, that's me done. I think that's over to Tim.
Have we lost Tim?
Tim? Tim can't appear to hear us, I don't think.
And also the slides have
The
gone
slides have been
a bit haywire. Tim, can you hear us?
He can see. I can see a smile there trying to get back. I know there's only a couple of left.
Yeah, there are only a couple of left.
Yeah. Can you hear me?
Yes, now we can hear you.
Yes.
Right, now I can't see the slides. Okay, so I think what David illustrates really well is how we need to get a systemic response to these kind of health-related poverty issues. There's lots of data that we're not using yet. We need to get much cleverer at doing that. And I thought Darren's presentation was really interesting today, because obviously a lot of that is being pulled together, but there are gaps about things like how strong is the voluntary sector in a certain area where there are certain health inequalities. Have we matched all these bits of information together? And examples like the debt stuff that they're doing in Southwark, really interesting work. But I think the challenge back to the ICS is do they know about David's? Do they know about the impact of those social conditions on their well-being? And, you know, there are things that we do know. For example, we know that social prescribing is very good for carers and it can reduce their risk of depression. We've got something like 10 years of experience of doing that now. We know that the independent living service, if it helps you with armchair exercises and stuff, you can prevent falls. We've got a fantastic Asian community group in St Albans where a guy's almost completely reversed his own type 2 through changing diet and is now working with his community on how they can do similar things. And Mary-Ann's already mentioned the pilot in central Watford. So I think this is all really positive stuff, but I think you won't get a system to act like a system unless it thinks it's a system and behaves like a system and people treat it as one. I think it's really important, all that talk about relationships today, because if I've learned anything in 30 years, it's that people don't put nearly as much time into networks as are needed for this stuff to work. They get obsessed with structures and reorganizations, relationships that make it work. But actually, there's a huge amount of support out there, both for professionals, so they can take the lid off the can of worms, but also for the public. And a lot of them can do it themselves. They don't need the hand-holding that you get from social prescribing. But what's really good now is we've built that social prescribing offer into the system, one-to-one support, and it's not just for people who need that little bit extra, it's people who need the motivation, the confidence, help over the threshold, the sense that it's worth going back to next time because you've had a bit of a knockback this time. That's where link workers are so important. And all of this is a crucial foundation for building back. And just lastly, we're trying to really build on the Herts Help brand and say, we're working together as a system so you can find that help that you need, that's right for you, and what matters to you. Thank you very much.
That's fantastic, Tim. I'm just going to ask you, thank you for that brilliant presentation, the three of you. I'm just going to ask you to have a look in the chat box and answer the questions that have come up specifically for the Herts. We're running a little bit behind time, so I'm going to pass over to Craig now.
Thanks, Sian, and thanks, guys. So it's my privilege to introduce Dan Hopewell, who won't need that much introduction, but I do love the title of Director of Knowledge and Innovation, because knowledge is great, isn't it? But if we do the same thing, we get the same thing. And as Michael was saying, that hasn't been very good. So if you haven't got a Director of Innovation somewhere, listen to what Dan's got to say, and then perhaps get one later. Dan, over to you.
Right, thank you very much, Craig. And that's interesting because I was also wondering whether we should think about implementation as much as what innovation. But anyway, okay, I'm going to do that terrifying thing of also trying to do the slide sharing, and let's see if it comes through. Seems to be a bit problematic on Teams. Can you see slides now? Can somebody, Craig, can you tell me if you can see slides?
We can see them, but they're not in presenter view.
Yeah, that's right. They should be coming through now, hopefully. Is that fine?
Thanks, Dan.
Yeah, brilliant. Thank you. Okay, so this is called Unleashing Healthy Communities, and it significantly, I think, plays to much of what we've been talking about through the day. And it's a sort of local version of many of the things that Michael Marmot's talked about this morning, the examples from Devon as well, but at a sort of much smaller scale. I was wondering maybe if this is sort of the grit in the oyster of to mix metaphors, of the Trojan horse. And this is going to talk a lot about what happens at neighbourhood level. And I think whilst it is really important that we think about, and Tim's just eloquently talked about how systems need to understand they are systems, in a sense, in a sort of even micro sense, we also need to get on and do it at neighbourhood level. And this is really what we're going to talk about Bromley by Bow. I'm going to give a bit of an introduction to Bromley by Bow itself, just because I think it's going to be important to understanding the rest of the presentation. So if any of you have come to Bromley by Bow today, but had arrived 37 years ago now, you'd have found a sort of dilapidated East London church. This was in the middle of the mid-1980s, levels of high deprivation. This was enormous levels of unemployment, and a community that had really largely been abandoned, and a church with 12 old folk on a Sunday morning, large and with extensive church buildings that were closed up during the week. And a new priest who arrived, Andrew Mawson, who's now Lord Mawson. Bromley by Bow today is very, very different, and it's been constructed by its community. In 1997, Tessa Jowell opened the first Healthy Living Centre in the UK at Bromley by Bow, a Healthy Living Centre really built by the community in response to its own needs, and a whole array of community provision, considerably provided by the community itself to itself. And Andrew, when he arrived, metaphorically and physically, with the agreement of a very generous congregation, flung open the doors of the church and started to invite the community in to establish a small community hub. Then about 12 years into our journey, we really realized that ill health and poor quality primary care were two critical issues that we wanted to tackle. Interestingly, at that point, our greatest challenge became the NHS. The NHS had actually never seemingly heard of communities building their own health centres. This was obviously either a job for the NHS or for the doctors, but not for small community charities as we then were. It was only really when Andrew Mawson managed to persuade Brian Mulwiney, the then Minister for Health, to visit Bromley by Bow, and this sort of emergent community hub that was bubbling away inside the church with a cafe and social care and artist studios and a bit of an ESOL program and welfare benefits advice and so on, that Brian Mulwiney understood the value of bringing primary care to this emergent community hub model and instructed the local NHS to start to talk to us about allowing Bromley by Bow to build a health centre. And so it was that the Bromley by Bow built what we believe is the first health centre in Britain built by the patients and rented back to the doctors. And at the same time, we persuaded the council to gift us on a 30-year lease that scrappy park that they were so much struggling to maintain. And we set about tearing up the tarmac and turning it into a beautiful 3-acre facility that we could build our Healthy Living Centre into and across, so that the external space and the internal space melded as one. And we sometimes talk about the principles of a community department store. We sometimes liken ourselves to the John Lewis of the social sector. We're owned by our community. Of course, John Lewis is owned by its staff. Accessibility is everything. You don't need an appointment to come to Bromley by Bow, and half of what we do are leisure activities. There's beautiful cafe, art classes, gardening, cooking, all sorts of other things that you might do with your family and friends at Bromley by Bow that are as much about creating opportunity as they are also our services around meeting basic needs. And customer service and really high quality relationships with our community are absolutely central to our model. And the array of, if you like to take the retail analogy one step further, the array of products and services. And this aerial view of Bromley by Bow gives you an idea of the range of provision that we have at Bromley by Bow. We have about 80 staff delivering non-clinical services, and then we have general practice as well. And when we established general practice, and Sam Everington, who was on the conference today, is one of our founding GPs, the whole premise of having general practice and having people like Sam and Dr. Julia Davis, who are the two co-founders of our general practice, was around social prescribing. And in the early days, it involved GPs literally getting out of their consulting rooms with their patients and walking them across to the team within the centre who might be able to meet their needs around maybe learning English or getting a job or doing some stained glass or joining a community choir or a gardening group or a walking group or whatever it might have been. Of course, today we have social prescribing link workers, and indeed 23 years ago, nobody was calling it social prescribing. Today we have 8 social prescribing link workers at Bromley by Bow, including mental health link workers, 1 link worker who's also a social welfare advisor, and young people's link workers as well. We also, within primary care, we have a whole population health team. So primary care employs a whole series of non-clinicians and has done for many years now, who work with patients and groups of patients in a sort of a way of health creation and managing long-term conditions and so on as well. And I'm going to talk about that a little bit further, but that gives you an idea of what you can access by coming to Bromley by Bow. It's probably worth saying that of the 12,000 people who access the non-clinical services, about 2,000 might be coming via social prescribing. The other 10,000 are referred by other organisations such as housing associations or walking in off the street. And of course, we know that within neighbourhoods, word of mouth is probably the strongest single way of promoting services to your community. So if you give good quality services, people tell others and they come to find out what's available for them as well. Public Health England's done a lot of research at Bromley by Bow, funded by them and Wellcome and Health Foundation. And this was the result of 2 years of embedded research at Bromley by Bow. So it's not just about meeting need, it's also about creating opportunity. And it's about a long-term vision. We've been working now for 37 years, as I mentioned. Creativity and fun are central to what we do, and building connection. And, you know, that's been talked about in the previous presentation, is probably one of the most critical things that we're doing. Let's talk a little bit about the social determinants of health. There's a street view of Tower Hamlets pre-COVID, and it's starting to look a little bit more like that again today. So in Tower Hamlets, just within a few hundred yards, we have probably a 20-year healthy life expectancy gap and a 10-year life expectancy gap, even though, you know, the one is in Limehouse, where there's a yachting marina on the Thames and all these penthouse suites and the old warehouse buildings along the Thames. And the other is Mile End, a very, very deprived community with a lot of housing estates. But they're both accessing the same GPs and probably both going down to the same hospital, the Royal London in the Mile End Road, if they get seriously ill. So we know, as Michael Marmot would tell us, of course, that these life expectancy and healthy life expectancy gaps are not down to GPs treating one set of patients better than another. That's kind of what it looks like in terms of those figures. This is actually from Michael Marmot's review. The important thing for us at Tower Hamlets and Bromley by Bow is that 70% of our population sit in that shaded area. It's a very, very deprived community. And this is what it does to general practice consultation rates. So if you look at the light green line, that's the most deprived, and you can see the advent of long-term health conditions probably in the late 20s and early 30s, and we're now starting to see type 2 diabetes at that sort of an age in Tower Hamlets. And then you have very, very high consultation rates from then onwards, such that by the time somebody's sort of about 60 years old, they're going to the doctors on average 8 times a year. Whereas their more affluent neighbours, as you can see, really long-term health conditions don't start to kick in till about 60 years old. And that's at that point, they are only going to the doctors 4 times a year. So we see a doubling of consultation rates against deprivation. And this has been said before, and Tim mentioned that 20% of consultations are, you know, directly driven by a social need anyway. But so one of the things is around social prescribing, around social need, but the other is actually how do we work with people with long-term health conditions as well. And we're going to talk about that a little bit. This is a bit of a poke at Cancer Research UK. You know, it's easy to say that cancer is caused by obesity, but, you know, that's the easy one to think about. But let's go, you know, the causes behind the causes. So, and some witty graffiti artist has put in there poverty, inequality and austerity. You know, let's look at the causes of the causes, not just simply the easiest thing to point the finger at. So this is Michael Marmot's review, and I won't dwell into this too much. And there's this lovely infographic from the Health Foundation. It doesn't include everything that Michael Marmot talks about. He talks about the life course as well. He also talks about agency, and Bromley by Bow is all about community agency. So that infographic hasn't quite captured everything that Michael Marmot has said, but it's captured an awful lot of it. So of course, these are the social determinants of health, and they can be both negative or positive. So I think the thing that we have to think about is, yes, we can all look at public health stats and the indices of multiple deprivation and understand what's wrong. But, you know, as you know, would be said also, we have to look at what's strong and how we flip these negative social determinants of health and turn them into positive ones, and how we build from the strengths within communities. This is a bit of a diagram. It'd be lovely if the NHS adopted this. This is a new way of thinking. And if we really believe that 80% of health outcomes are socio-economically determined in the community, maybe this is really how we should be thinking about the health system. You know, what is primary, secondary and tertiary care? And the NHS should really be seen largely, as it genuinely is, as an insurance policy for what you do if things go wrong. And you know, the magenta segment there is our social programs, if you like, and the green segment there are clinical programs. And of course, the important thing is how they work together. And a little reminder at the bottom there from one of our friends, Professor Martin Marshall, who's the chair of the RCGP, who at the conference last autumn said that social prescribing represents the greatest cultural change in the NHS for decades. I think it's actually probably the greatest change in the NHS since it was founded in 1948. And as such, I guess we have to have a little bit of patience in terms of the speed of change. So there's where we are, Bromley by Bow, top right there. And this is talking about the community hub that we are, the medical practice, and then the team that I head up at Bromley by Bow, which is called Bromley by Bow Insights, that carries out research and evaluation, supports ongoing innovation, and shares knowledge with others. And now I'm going to talk about how we're working with the primary care network. So that's our primary care network. Those grey bars are the 4 main roads, and the yellow dots are the GP practices. That, in a sense, is the current NHS understanding of what a primary care network is, which is, you know, a group of GP practices, approximately 50,000 patients, and it's all very clinically based, really. But let's think about this, and this is kind of applying some of the thinking that we've been developing with Merrin Simpson and others around health creation, which is how do we move beyond a clinical primary care network into something that's around health creation, and how do we do that, as that lovely diagram behind the words there illustrates, by building the relationships of people within those areas. As Tim said, it's all about building the networks and the relationships, and we'll talk about that now. So this is sort of primary care networks 2.0, or as we're calling it, health creation networks. That's the same GP practices, as you can see, but look at all the other players that we brought into this network: housing associations, community centres, faith organisations, children's centres, nurseries, and primary schools, secondary schools, which very much talks to Michael Marmot's concept of the life course. But a whole range of connector roles as well, a common directory, a common website of services that serves that area, common training for frontline staff as well. So as well as social prescribing for social prescribing and referral from clinicians, what about training up a lot of frontline staff within these organisations to do something called social prescribing light, for example, where they're trained in the basic principles of social prescribing and have access to that common directory of services, know how to signpost or refer people to those services, and know how to send people to the social prescribing link workers if they need a greater level of support than that light touch version of social prescribing. So this is kind of, how do you harness the ability of each of those organisations to generate health, for example? So how do you ensure that your schools have got a healthy schools policy, that you've got walking buses from the housing estates to the schools, and you're trying to, you know, disencourage people from the school run, for example? How do you make sure there's food growing in every school, healthy meals in every school, that every school is implementing the mile a day run, for example? How do you work with housing associations to ensure that, you know, there's good quality green environments on the housing estates and so on, all those sorts of things? So how do you maximize the health benefit that each of those organizations can generate by doing what they already do, but doing it in a conscious way, thinking about health creation? And how do you bring it all together? And how do you have a good system of making every contact count and access to services promoted by, as I say, a common directory? And so we'll talk about some of that we're doing. One of the interesting teams that one of the ways that we bring frontline staff together is something called E3 breakfasts. We have an informal breakfast for the frontline staff of about 30 to 40 organisations in the neighbourhood, who meet up every quarter to get to know each other, understand how to cross-refer, understanding what each other's programmes are. But we also have a community asset building team at Bromley by Bow called Communities Driving Change. In fact, we've just about handed them over to our primary care network. This was a programme previously funded by Tower Hamlets Council's public health team, and they worked on housing estates and communities around building health and well-being assets within those communities. And they basically did dedicated outreach to those housing areas. Now that funding stream, because of local authority cutbacks, has come to an end. And what's really staggering for us is that our primary care network have adopted that team. They are now seconded from the Bromley by Bow Centre to our primary care network with funding that comes via our primary care network to employ them to carry out this health creation work across the whole area now of the primary care network. And based on some research that we've done over the last couple of years, our primary care network have adopted children, young people and families as one of its top priorities. So the Communities Driving Change team are now working across the primary care network in a health creation, health asset building way, and working very closely with social prescribing link workers and many of the organisations that were on that previous diagram of the health creation networks. So that's one idea. How do we change primary care networks into health creation networks? The other, and I mentioned this a little bit earlier, is around long-term health conditions. So this is really taking some fantastic work done by a whole range of different organisations. So Bromley by Bow ran for 4 years a social prescribing scheme for people living with and beyond cancer. We've just completed 6 years, as you know, of Ways to Wellness, probably in Newcastle, a fantastic project there. Again, working with people with long-term health conditions from 40 to 74 years old, staggering results, £1.5 million a year being saved to the Newcastle health system by Ways to Wellness. We've run an amazing project at Bromley by Bow called DIY Health, which is working with parents with very high consultation rates with their children, very young children, coming in with sort of coughs and slightly elevated temperatures and rashes and so on. And so we developed a whole program with them around how to look after your child and how to feel more confident about your child's health, which again reduced consultation rates considerably as well. And lastly, but by no means least, the fantastic work that Michael Dixon and his wonderful social prescribing link worker Ruth Thakur did down in Devon, which was a special social prescribing scheme for people who were either diabetic or pre-diabetic, with absolutely staggering results in terms of, so it's all around lifestyle, it's around healthy eating and exercise and all that sort of thing, with staggering results in terms of people who are diabetic coming down to pre-diabetic levels and people who are pre-diabetic coming down to normal. So we've done a lot of thinking about this, and we did also a lot of work, like many social prescribing schemes under COVID, around using data within the general practice to understand who we should be targeting for all of those outreach phone calls that we all did under COVID. You know, thinking about people who were living alone, people who were low mood, who had anxiety, depression. So now we're starting to think about data-driven social prescribing. So we have responsive social prescribing at the moment. Of course, that's what we've all been doing, which is where patients walk into the consulting room, mention a social issue, and that leads to a social prescribing referral. But what about using data to drive the contact? And what about then identifying whole cohorts of patients for whom we then proactively offer social prescribing? And this is what we're now starting to develop at Bromley by Bow. So the first tranche of patients are going to be patients with long-term health conditions, and that's about 6,000 or 7,000 out of a primary care network list of about 58,000. And we are starting to profile those now. And we're going to be doing this by, one of the tricks we've learned from NUCA is about how you sit people together. So we're going to be sitting a section of our social prescribing link workers together with the long-term long-term condition management team, who are doing all of the proactive calling and recalling of patients and booking them in for appointments, to start the offer of social prescribing right from that first phone call. And we will be having a conversation with them about those 6 areas of their lives that are on the right-hand side there. So this is a bit like using a well-being star or something like that. So it's having a proactive conversation with those patients about how they're getting on with their life, what's going on for them, building a relationship with them, not just about their health issue, but about social issues, and about triaging and referring into social prescribing right from that initial phone call that you have. And these are phone calls that with some patients are every few months, of course, particularly if they have multiple conditions. And then, of course, how you train. So you need to train up the telephony staff, the call and recall teams. You need to train up the healthcare assistants and nurses about how do you build a new long-term condition management pathway that has a dual pathway, one about obviously about the long-term health condition, but also about social need as well. And this is what we're busy constructing at Bromley by Bow, this dual pathway for people with long-term health conditions, so that we're supported, because the correlation is absolute between people with long-term conditions and people health conditions and people with long-term social conditions. So how do we create a single pathway where we're supporting them around both? And that's the next step, and we're just implementing that now. I'm going to skip over that slide, but that's the program that we ran. That involved a children's centre as well as Bromley by Bow and Bromley by Bow Health, and an academic health science network, which, as I say, did all of the research around the consultation rates and showed dramatic reductions. Lastly, and some of us have been talking on it today about measurement and evaluation. At Bromley by Bow, we have constructed an outcomes framework with our community. We spent a couple of years working with our community, talking to thousands of people, and including dozens and dozens and dozens of in-depth interviews to ask our community what matters to you, or what are the ingredients of a good life. Because if there's anything that all of us should be doing, of course, that's helping our communities to live good lives, both as communities and individually. And so from that, we've created a community-informed outcomes framework, or as we like to say, measuring what matters to our community. And indeed, we all know that by measuring things, you make things matter to systems. So if we can measure what matters to communities, we can therefore make what matters to communities matter to systems as well. So we're just in the process now of implementing these 6 stretch outcomes across our non-clinical services. And we've got an indicator set of about 40 indicators. It's all on our website if you want to have a look at it. And then the next step will be to apply that to our clinical work. And the first stage of that will be applying that to our program of working with patients with long-term health conditions as well. So this is going to be, I think, revolutionary. I think it will lead to significant service redesign. Can you imagine designing a program for patients with long-term health conditions that had this as a set of outcomes that it was trying to achieve? You know, building reciprocity, mutuality, building people's ability to contribute and co-produce, connection to others, connection to place, learning skills and capabilities around their health needs and so on, as well as meeting Maslow's hierarchy of basic needs. So that's a process that we're undergoing at the moment. As I say, it's all on our website. It's been funded by Health Foundation, Wellcome and Public Health England. We're very excited about it, and we'd be delighted to talk to anybody who is interested in this kind of community-informed outcomes framework and how you might want to do something similar for your own community. I'm going to hand back to you now, Craig.
Dan, thank you. Thank you. That was fantastic. And I suppose my view of moving back into the integrated care system, the ICS, which works with place, or what they call in places, is that it's all about community. And I've got some pilots I'm going to be leading in Luton, and I'll be touching base with you about that. And I do think we've probably got the best chance we've ever had. Unfortunately, I think that's driven a little bit by the fact that we've run out of money, so we have to do stuff together. But actually, if that is a negative, let's try and turn that over into a positive. So thank you. And I'm going to hand back to Sian.
Thank you very much, Craig. And thanks, Dan. As always, a very inspiring talk there and some fantastic achievements. I am going to throw it open to the floor for some questions from attendees in the session. So we have a little bit of time here till 1:15. So any hands up we'll keep an eye out for, or just alternatively post it in the chat box. In the meantime, I'm going to pose a question to Dan. What has been your biggest challenge in the journey so far in terms of allowing social prescribing and health creation and the biopsychosocial model of health to stick in your communities?
I mean, I think we face immense challenges, and I didn't want any of what I said to make it sound easy. Much of it is work in progress. And as our chief executive at Bromley by Bow likes to say, nobody funds the Bromley by Bow model. I mean, the work of the charity, the non-clinical work, is funded by 50 different funding streams every year. We have to kind of put that together like some sort of amazing tapestry to create the model. And I guess what is the challenge, I think, is probably the funding for that kind of critical headspace, the thinking space, and the kind of design and development space. A lot of what I'm talking about needs a lot of that, and that's undercooked. And I think progress would be much faster if we had more of that. So I think that is probably the challenge. I think there's an awful lot of goodwill. I mean, as Craig, you've said, the systems run out of money. And I think everybody's coming to the same conclusions, whether you're in the housing business or whether you're in schools or whether you're in health or whatever. I think everybody's coming to the same conclusions, actually, that we need to do this with communities and we need to do it together. And so none of us can solve these challenges as single services. So I think we are really moving into a new way of thinking. And I hope that will kind of unlock a little bit of the resource that's needed to kind of do the knitting.
That's really helpful. Thank you, Dan. Tim, are you coming in with another comment on that? Because
I was going to ask Dan a question, actually.
Yeah. All right, I've got a question from Vicky first in the chat box, then I'll come on to you. So, question for Dan, tips on community engagement that will influence system service development. There you go. That's an easy one.
So I think you have to start by taking a commitment to co-production. I think you need community outreach workers. You definitely need really skilled either community researchers, and that's actually one thing I forgot to mention. We've done some really interesting research with patients with long-term health conditions, for example. So we've got a team of trained community researchers. So creating evidence for what you're trying to do, I think, is important, such as that community research and we've done some really interesting, we interviewed, I think, about 32 patients with long-term health conditions, trying to understand what would help for them in order to help us to design pathways, for example. So creating some evidence base is important. Making community engagement and community research fun is really important. So you need to do things in community centres, in parks, in wherever people are, you need to go to them and where they are. But you need to get a commitment from the system that we will co-produce and co-design with the community. And the system has to trust local people to come up with good ideas. One of the things our GPs have done, which I also forgot to mention, is we now have a community advisory board that our GPs have trained as local people. This is very, very different from a PPG, by the way. But they are there helping to co-construct what primary care needs to look like. And we've now got a board of we've got a board of directors for our primary care Bromley by Bow, which includes some of these some of the members of the community advisory board as well. So you have to start to build that commitment, and the system has to learn to trust people and has to learn to share power with the community. And that's kind of needs to be a step-by-step process, I think.
That is amazing, Dan. Thank you very much for sharing all of those extra examples there and answering Vicky's question as well. It's no mean feat by any means, but actually the only way that we will get this to stick is that actually the communities that we are serving actually own this and lead this with us as equal partners. Tim, your hand's gone down.
I see Johnny's asked a question. I thought I finally hold back, I think.
Perfect. Question for Dan, and this is possibly one of our last. Is there a plan to make monitoring of the outcomes you describe for non-health services in the health centre also? Do you think GP practices doing this could shift a focus to non-medical and use of wider sources of community resources?
So, yes.
Measuring outcomes.
And I think what's going to be really interesting about the stretch outcomes framework that we have developed, and when we start to apply it into the clinical sphere, is it may support a redesign of how clinical services themselves are delivered, but it will absolutely, I think, re-emphasize the importance of the social determinants of health to clinicians, and kind of understanding by clinicians understanding what matters to patients, therefore understanding the importance of that. I mean, we're very lucky at Bromley by Bow in the sense that we've got a whole set of clinicians who understood social prescribing before it was even called social prescribing. But I think that will be helpful. And I think that as we start to see more and more non-clinical staff employed within general practice, I mean, we've got link workers, we've got care coordinators, health and wellbeing coaches, care navigation now within reception and so on, we will surely inevitably get to a tipping point where primary care starts to, as well as retaining its clinical focus, will also start to look more like public health. And what gets delivered within primary care will be a hybrid of clinical work and, how do you work with groups of patients around long-term conditions and health behaviours and so on. I mean, we know anybody within primary care who's done any financial modelling will tell you that within a few years, particularly in deprived communities, there just will not be enough budget to pay the amount of clinical time needed to support the people with long-term health conditions. We inevitably have to move to a system where we go to group consultations, a lot of group work with people with long-term health conditions, because there just will not be enough money there. the number of patients in our primary care network with diabetes goes up by a third within the next 8 years. And you think about all the health checks they need, all the support they're going to need. There literally is not going to be enough money in the system to provide that.
Absolutely. Thank you so much again for those reflections. I'm just wondering, I don't want to put you on the spot, Kristy, but as somebody from local authority, do you have any reflections on what Dan's saying from Bromley by Bow as to how that affects you in Hertfordshire? Are you hearing and feeling similar experiences?
Yes, Tim, did you want to come in? So I see that Tim's got his hand up. I just wanted to check whether, did you want to answer?
I can, no, you answer that and then I'll come in.
Yes, no, I would agree with what Dan was saying, and you know, definitely in Hertfordshire, what we're seeing at the moment is that yes, things look okay in terms of being able to fund some of these services that we've started, but being able to sustain them more than a year, I'm really worried. I'm really nervous, and I think things will drop off a cliff edge. And you know, we started some brilliant projects, and we're going to have a larger need and not enough funding to be able to cater for it. So I'm very worried about that.
Thank you for those reflections on those risks there, Kristy. A very worrying time for all services, and I think this is why that Trojan horse of collaboration, co-production, working together as a whole system is going to be absolutely key to all of our successes. Tim, coming on to you, and then I'm going to give the final reflections after that to Craig.
Okay, so it's really following on from Dan's point and Kristy's as well. And I'm thinking about what Daisy Fancourt was saying at our regional conference last week, and that if you carry on treating mental health as primarily a biomedical thing, then we can't afford to deal with it in a biomedical way very, very soon. We've got to get much better at treating human distress before it becomes sort of disease that's clinical. And I just think this whole way of working, what Dan's been describing, is absolutely fundamental to getting upstream of all that and stopping it becoming, so it's not just diabetes, it's mental health, it's all the stuff around kids and their futures. It's actually the sort of public health approach to, you know, knife crime, for God's sake. It's the whole gamut. You can wait for it all to go pear-shaped, or you can try and constructively do something about it, which is what Marmot was talking about this morning, isn't it, really?
Absolutely, yes. I think there's great alignment to the presentations we had this morning and the reality of how that shapes in communities with the two fantastic examples we've had here today from Hertfordshire and Bromley by Bow. So I'm going to pass over to Craig for final and sort of closing comments and reflections from him, but also to say thank you to our speakers as well at the end.
Thanks, Sian. It's a wonderful place we are, isn't it, really? And I suppose my main reflection, having been here for such a long time on this process, is when I first started talking about this, people thought I was away with the fairies. Now they just think I'm optimistic, which is a huge improvement, isn't it? And, you know, people want to do this stuff. And I put in the text box there, as some countries already do. If we were measured wellness as part of our GDP, that would be valuable, because having a few people of extremely high net worth increases a country's GDP, but it hides actually the majority of the challenges that are there and allows us to put them to one side. And so, you know, I felt really confident in moving back into the NHS, which colleagues on this screen will know that, you know, I dip in and out between the VCSE and the NHS, because I do believe that the NHS is open to working with other partners now. And I am seeing that, not as much as I'd like, but I am seeing it significantly more than I ever have before. And colleagues would also know the phrase opportunity in the face of adversity. And I don't really like the word of opportunity, but I can't think of anything else to use. You know, maybe necessity is a good one. But I think what we have realised, what the pandemic has shown us, is that having lots of people in inequalities impacts everybody. It impacts the whole system, the NHS, someone who drives your food to you or cleans the house or whatever it is. You know, everybody is impacted that, and by bringing everybody up to, you know, a minimum level, then everybody benefits from that. And I think we haven't seen that before. So that's all I'd like to say. I think there's some challenges ahead, but I think there's so many of us now that want this to happen, and people like Michael Marmot, sort of getting more and more vocal, which is wonderful. I love it when he does that. I might prod him a little bit more to get even more vocal. It can only be a good thing. So thank you, everybody. I think the slides are available afterwards. Thank you to all of our speakers. Wonderful as ever, and enjoy the rest of your day. Take care, everybody.
Thank you.
Thank you.
That was good.
That was great. Numbers stayed high right all the way through, which is really positive.
So the highest we reached was 97.
Yeah.
Oh wow.
And we only went down to 88 at the very end.
Oh, excellent. That's good.
So they were obviously extremely engaged in what was being said, and thoroughly enjoyed you all.
Yeah, it was really good. Really
Sorry
good.
we ran over.
That's okay.
It's a funny thing, Dan, isn't it? Because you want people to stay to time, but then you want people who are passionate about what they do.
Mm.
And you know, I don't want someone to come on and go blah blah blah. I'm going to stop now.